Well, I'll just show you two little videos. One is for an enhancement post smile. This I just did this morning, so it is commercially available now, the circle scan. So you can see we applanate, and this is applanated, and this we are going to 7.9. So at the same thickness where you had the earlier cap of the smile, you have gone and you have created this, which is about 4.5. And it is very easy to lift it, and you can see that this is, you can lift this and it becomes a flap. This is the earlier lenticle from where it was taken, and you can make it into a flap and go ahead and do laser ablation on this. So this is a circle scan which is available. The circle scan can also be used if you have any little bit of lenticle that is left. So immediately at the same time on the table, you could go deeper and create it into a flap and do that. Okay. So this is just to show you. There was some people who said that you really can't do anything. That is a common thing that is being told to the patients. Post smile, you cannot do an enhancement. You can do an enhancement either as a surface ablation, or with the circle scan, you can make the cap into a flap. So that is what I wanted to show you, being commercially available. So this takes care of that problem. Sorry? Enhancement to eczema se hoga na? You're making that into that, so it's like an eczema. So you can't do a smile, or you can't do a re-smile on a smile. You can't make a lenticle, but you can burn as much tissue as you want in this thing. Just to show you two other videos. This is the white cell reaction that I told you in the intracorneal ring segments, and this is the melt which questions were asked. You can see this is vascularization, and this is after the removal of the ring segment. This was a melt, but you can still see a white cell reaction in the other segment. So this is typically what you can expect. This patient was from Middle East and had gone back and didn't come back to me, so came back with the protrusion of the ring segment. Now, one thing is that I am not anymore doing a CXL for an intracorneal ring segment following a CXL, because you need to possibly reset the parameters. So this was when I migrated from FS60 to FS150. Plus this was a CXL cornea. You could see we are making the pattern here, and you can see that this is not as good as the rest of it. This is the side cut that has been made, and the cornea is obviously, the rigidity of the cornea is different. And then you go ahead and can you see this air bubble there? Can you see that? So there is something which obviously I didn't have that much of experience, but now that I have, this is the one and the only time I have had a problem. So you can see this kind of problem. So you can see that we are putting the first ring segment, it is fine. And then we go ahead and take out the second ring segment and put it in. Now you see when you put in the second ring segment, that's the air bubble. Just watch the whole thing going in. And you can see that I am having some difficulty in pushing in the ring segment, and just watch here. There is difficulty, and just keep watching here. Can you see that air bubble? Another air bubble went in, and we will just push it, and you can see it is much more free. Can you see that? But I didn't realize it at that time. I just went ahead and put in the suture, and that's when the next day I saw that the ring was an intrusion. I showed you an extrusion, and I'm showing you an intrusion. So it was an intrusion, and therefore we have to go ahead and remove the ring. I told the patient that I could remove one ring, but the patient was so upset that she said that no, I want both the rings to be removed. So you can see this also shows that the ring segment is a reversible technique. So you can see that we are removing this ring. You just go with a Sinski, there is the hole there, and with the hole you pull it out and use a forceps to take it out. Now this is half in, so what we do is that we make a side port, push in the ring, and just pull it out from the other side. So ultimately the patient had a C3R done, and you can see this is how it looks, and this is how it looks post-operatively. So you can have this. Now thin corneas is the other thing that we were talking about. So hyperosmolar riboflavin, that can be used, transepithelial CXL, or you could use EDTA, or you could use a silicone ring which could contain this. And Susan from Agarwal's has put in a contact lens on top of the cornea to kind of do this, but since the contact lens could not fit well on a soft contact lens on a keratoconic eye, you could have pooling of the dye and the results could be different. So what we have designed is this is tailored stromal expansion with refractive lenticle for ultra thin corneas. And we have done a couple of cases with them with good results. I have no financial disclosure for this particular thing. As you can see that when you are looking at a keratoconic eye, this is the cornea which tends to bulge out in cases of keratoconus. And what you want to do is you'd want to do a CXL in which you have to remove the epithelium. There are several ways by which you can remove the epithelium. And we normally use the epithelium to be removed, but then you should look at the corneal thickness after removing the epithelium, and that is what is supposed to be more than 400 microns for you not to cause damage. But when you have corneas which are very thin, what we have done is that this is a smile, as Dr. Rupal had showed. So we are doing a smile in another patient. So this is not of the same patient, this is another patient. And once you have done the smile, you just take out the lenticle. The thickness of the lenticle that you are removing is known to you, and basis the thickness of the cornea of the keratoconic eye, you could tailor a particular lenticle that you would use to put the lenticle, and you would want the lenticle to be put on the part of the cornea which is the thinnest. Okay? So we have put the lenticle, and therefore now if you look at the corneal stromal thickness, it is more than 400 microns. So I'll just show you the real life images. So then you put the drops, as you can see, and do the CXL. So you see here, this is the lenticle, this is the UV radiation that is being given, and then you go ahead and after the procedure, since it's a cross-linked cornea, there is some adhesion that has formed over time, but you can easily peel off the corneal lenticle that is there, and you remove it and then wash it, and you get the procedure completed. So this is, I would say, you could tailor how much expansion you want of the stroma basis the cornea that is on the underlying cornea. These are the results that you can see. They are pretty good. And you can see that we have gone on to the epithelium of stromal thickness of 326, 321, 382. So these are the cases that we have done with excellent results. So the lenticle, if some people asked, it can be easily transported in an MK medium and it can be used by somebody else. So lenticle uses are coming out with smile. As I told you, Philly, Dr. Shri Ganesh will be talking about, that is use of a lenticle taken out from a myopic patient, put in a pocket for correction of hyperopia. Thank you very much for your kind attention.